We always talk about diabetic foot disease, and there is a lot of forms of diabetic foot disease, one of which is when you lose sensation and therefore you end up with some bony destruction, what we call Charcot's foot. But a lot of diabetic foot disease is actually vascular in cause. And so many people say, well, it's just maybe the nerves are bad and that's what's going on. But that's actually the minority of cases. Most of these people have concomitant significant arterial blockages. And so this is very important, and getting back to the disciplines working together, each discipline brings a certain level of expertise. And that's why we put these disciplines together early on. And no one discipline has given us all of the treatments that we have. In fact, each of the disciplines I mentioned before, interventional cardiology, radiology, surgery, podiatry, wound healing experts, the list goes on. Each of those areas have contributed mightily to limb salvage. And I really believe that we're on the precipice of being able to treat almost everyone at this point, particularly with new techniques such as deep venous arterialization, where even when every vessel down to the minute vessels of the legs, the minute arteries of the legs, are severely diseased, we now can convert one of the paired tibial veins that go to the foot, convert it into an artery by making a channel from an artery into that vessel. This is called deep venous arterialization. And in that group of people who were originally thought to have no hope, no chance, already limb salvage rates of better than 60% are occurring. And I think we'll get better as we learn more about that technique. So this is a field which has evolved tremendously. I would say, though, however, that the treatment has evolved faster than the capacity to diagnose and refer has evolved. And there are many reasons for that. One reason is there aren't enough doctors right now trained in this, to really reach out and treat all of the patients. Secondly, there are wars going on sometimes between the different disciplines. I don't understand it. It is not as though there's a shortage of patients, not at all. And patients are suffering with this. And I think it is very important for groups to work together. And that's been a theme of my practice for years and years. And I do go to the surgical meetings. I do go to the radiology meetings. I speak at those meetings. And sometimes I go into a hostile crowd, but usually that works out very well. Okay. And I think it's what we have to do. We cannot remain silent on what has to happen for this disease process. And, I would just suggest to people that anytime a boat moves, it makes a wave. But boats are not made to simply sit in the harbor. And doctors are not made to not make a wave. Their purpose is to treat patients. And whenever we speak about changing the way patients are treated, that causes angst because people are used to doing something in one way. I've never been quite bitten by that bug because I've always believed the philosophy my father had told me. And he said, Craig, change is not always better. In fact, change is sometimes really bad, but you can never get better without change. And I think that's a very important guiding light. And we do have to change when we see things that are tangible and good, and that can help us. And that's what I'm hoping we can achieve with the outreach that we've done. And, recently, I think we've had some setbacks in terms of patient care. I'm sorry this has happened. I hate seeing this. But even at this meeting, I saw doctors coming together, speaking, this is right, and bonding on the things that we have in common, rather than fighting over which discipline should do this or other things. It makes no sense to me and never has, and I doubt if it ever will. I think that our first contract is not to a discipline, but to our patient. And I think we owe it to each of those patients to do the best we can do.